Please watch all the way to the end. Don't forget to like and subscribe. Please leave a question or comment at the end. We'd love to respond. Don't forget, please check out our website at www.mypfi.org. So prolapse, as we talked about extensively in our introductory video, prolapse is a turning inside out of the vagina. The vagina is normally a long tube that's pulled up on the inside, held in place by ligaments and zippered to the insides of the pelvis. Childbirth can stretch those ligaments and stretch the vagina and break the zippering so that the vagina turns inside out on itself. When a woman experiences that as pressure or a bulging out of tissues, that's called prolapse. That's what prolapse is. So if I make the analogy of a flag on a flagpole, if I go up to the top of that flagpole and cut the rope that holds the flag up, the flag falls down. There's no amount of chanting, medication, flag waving, or non-structural things that I can do to make that flag go back up. The way to fix that is to retie the rope around the flag, pass it through the loop in the top of the flagpole and pull it back up. That's a structural fix for a structural problem. Similarly with pelvic organ prolapse, once it's determined to be a falling down or falling out of the vagina, there is no medication that you can use to correct that problem. It's a structural problem. It's not fixed with pharmacologic methods. So if someone is telling you that they're going to give you a medication to cure your prolapse, run, is what I would have to say. Question again is there a biochemical solution to prolapse? At this time, the biochemical solution is to use your own tissue to re-suspend the vagina and pull it back up into place. It's a structural problem that is fixed structurally. So the biggest risk for prolapse, we believe, is vaginal childbirth. You push a 10 centimeter baby out through a 2 centimeter gap, the vaginal tissues will stretch, the ligaments will get pulled out. The big defect hiding behind all of this, and this is based on some work that we did back years ago with our 3D MRI work, where we looked at levator ani subtended volume, LASV, where we looked at the shape of the pelvic floor muscles that surround the vagina. Actually, normally shaped pelvic floor muscles present a shelf that the vagina helps to sit on, and it helps support the zippering of the vagina to the sides. So if those muscles are broken or gapped out so that they're not supporting the vagina, the risk for prolapse seems to increase. And that's based on some structural analysis that my group years ago did with 3D MRI reconstruction and biomechanical analysis and so forth, which we can talk about at another time. So that said, if you can look for ways to rehabilitate the pelvic floor muscles to accommodate a vaginal delivery better, if you can pre-stretch the pelvic floor muscles or pre-relax or pre-untighten or pre-loosen the pelvic floor muscles enough so that vaginal childbirth is facilitated with a good-sized, normal-sized baby, if you allow those muscles to stretch normally during the birth process. So it turns out muscles stretch if you stretch them gradually. If you stretch a muscle suddenly, it tends to rupture. If you rupture the pelvic floor muscles, then their ability to resupport the vagina is in doubt. So what you can do to help the pelvic floor in advance of delivery is rehabilitating the pelvic floor muscles so that they have the ability to stretch gradually during childbirth. One of the methods that old school midwives used to talk about was, for example, massaging the perineum. So they would basically do physical therapy on the pelvic tissues at the opening to help relax those tissues so they don't tear when the baby's head comes out. Another old school technique that midwives talked about way back, long before we had biomechanical analysis of these tissues, was if you could massage the pelvic floor, do physical therapy on the pelvic floor muscles during the pregnancy to help prepare the pelvic floor for the vaginal delivery, that can also help. The third thing is that in this day and age of nobody wants to have pain with with vaginal childbirth, if we could do something to let the baby deliver down near the opening before we start forcing labor on a woman's uterus, we can actually pre-stretch the muscles in labor so that the muscles are pre-stretched, so when the delivery happens, the baby falls out, so it's not a sudden trauma to the pelvic floor muscles to break them open. That's called laboring down the head. So we heard that term in the 60s and 50s. Midwives coined the term way back. So if you let the labor happen, so you let the delivery process ensue, so that the baby slowly comes out the birth canal, delay onset of the epidural or spinal, don't call for pain medicines too soon, don't allow use of forceps delivery or vacuum deliveries to pull babies out in a fat hurry, within the limits of obstetric limitations. If you do those kind of techniques, we believe many obstetricians, mostly the old school midwives, and some of the newer ones, I haven't talked to them recently, but some of them also believe those techniques help ease the birth process to let the baby come out in a more predictable way, stretching the muscles. And if those muscles are appropriately stretched prior to delivery, then they can go back to serving as a nice shelf for the vagina to help prevent prolapse. I don't know about medications that are used to help soften the pelvic floor muscles to prepare, but if you're looking for a preparation, that's an example of something that has been known for decades, maybe even centuries, to help decrease the risk of pelvic organ prolapse. There usually are not medications that are used to treat prolapse because prolapse is considered to be a mechanical, structural problem. Don't forget to like and subscribe. Please leave a comment or question. We'd love to respond. Don't forget, check out our website at www.mypfi.org. Thank you for listening.